Also, good afternoon, everybody. Welcome to you all for this Cystic Fibrosis Awareness Program. For this program, I welcome our chief guest, Professor Dr. Sneha from Christian Medical Bangalore, who is an expert in this field. I welcome her for this awareness program for all the postgraduate students, IAP members, and faculty members of Madurai Medical College and Vellamma Medical College. I welcome all the faculty who accompanied her, all our organizers, Dr. Jenish and Dr. Karthik. Welcome to you all. Thank you. Over to the program.
Face this way. You can lower this is yeah. Okay, thank you for this opportunity. I'm Dr. Sneha Varki. So I'm going to give a little overview of the topic of cystic fibrosis. Many of you may be familiar with the condition and may have managed some patients. I'll be just giving an overview now. So we are running a project called CF India project. So it's a collaborative project between our Department of Respiratory Service and CMC Vellore and hospital in Columbus, Ohio. And we are supported by a grant to do some of the activities of this project. The activities being to create awareness among doctors and other medical professionals in India and to help parents look after their children with cystic fibrosis and develop a multidisciplinary care. So you can see my team, some of the members of my team, that's an old photo. There are some more newer people in that. So we do the work with the help of all of them. So in this talk, I'll be covering a few important points about cystic fibrosis. So if you look at the history, before 1913s, there was no word called cystic fibrosis. Nobody used that word. Children with malnutrition and diarrhea were treated as celiac disease. That was the disease which was known then. Through various dietary manipulations, they either gave fat or didn't give fat, gave certain vitamins, etc. That is how celiac disease was treated. Yeah, then Dr. Dorothy Anderson, a pathologist, is the first one who said the name cystic fibrosis because some of the patients they thought had celiac disease behaved differently because in the autopsy, when they died, the autopsy showed pancreatic involvement, which was not the case with other celiac disease. So that is when the name cystic fibrosis came. But the disease existed much before that. Even the previous century, there were stories or folk tales saying if a baby has tastes salt, when the mother kisses on the forehead and the baby tastes like salt, that baby won't live long. So that was a saying even in the previous century. So the disease existed before, but it got a name only in the 1930s. So there were very limited options for treatment then, didn't know what was happening, so treatment options were also limited. During World War II, when penicillin was identified as a drug, there was a dramatic change because the children could be treated with some antibiotic and the infection could be controlled. And there was such a dramatic change in their life because before that they were just dying of infections and penicillin changed that. So that was around the World War time. Another name used at that time is mucociliary. You may have seen that. In the next 20 years, there was rapid development in the West, and doctors identified what are the treatment regimens which work. They identified there is a problem with the lung, the airways. Clearing the airways through different methods will help the patient. Antibiotic use will help the patient. Certain dietary manipulations and use of enzymes to aid digestion. So these were the development which happened in the next 20 years, and that really changed the scene. Before that, babies were dying at 1 year or 2 year maximum, and they were able to raise the life expectancy into their second decade, even up to third decade, when they could treat with certain medications and certain procedures. So around the same time, India also reported the case of cystic fibrosis from AIMS, and our own department reported in 1980, that is from Tamil Nadu. These are Tamil Nadu patients. From 1980, it is known cystic fibrosis exists there. But just that it did not get any importance, like TB or HIV or, this disease didn't get any importance. So all the initial treatment strategies were actually done just by trial and error, without understanding why it worked or what will work, what will not work. They didn't know. They were just doing trial and error and adopting whatever worked. But later, the advances led to the identification of the gene, the CFTR protein, cystic fibrosis transmembrane regulator protein, and then some of the treatments were correct. Maybe some of the treatments were not correct up till that point. Now we will look at what exactly happens. Now we have the knowledge, so we will look at what exactly happens. So CFTR protein, it's a gate or a channel protein situated on the surface of the cells. Cells means many cells, mainly the cells lining the tubular structures in the body. So the airways, the intestine, many ducts in the body, these cells have the CFTR protein. So the function of this protein is to allow chloride ions from within the cell to the outside. That's the function. So in the lung, this has a very important role. As you can see, the ciliated epithelium, that is, we have studied ciliated epithelium of the respiratory tract. The cells have the CFTR protein. If they allow chloride ions to come from within to the surface where the cilia is situated, the mucus layer will be very thin, because if chloride comes, sodium also will come, and when sodium chloride is there, that layer will be very well hydrated. Water will remain there if sodium chloride is there. Whereas if the channel is blocked, CFTR protein does not function, or the channel is not there, the mucus layer, as the thick layer you can see there, will be very thick and dehydrated because there is no fluid, there is no water there. So this is the basic mechanism. This was identified many years later. We were looking at the history. This was identifying this problem helped in many ways to target where the problem is. So if a normal airway looks like that on the left, the CF airway will be clogged. The cilia will not be functioning, so all the secretions will be there, and the airway, you can see there is hardly any space for air to move. It's a clogged airway, and it will be purulent secretions will be there, lot of neutrophils, lot of bacteria, everything will be there in the airway. And you can imagine what kind of problem that will lead to the child if you have such blocked airways. Not only the lung, it will affect every part where there are tubes. So the nasal passage will be affected, GI, gastrointestinal system, intestine, biliary tract, pancreatic tract. Pancreas is very important here. In the male, vas deferens. These patients have congenital bilateral absence of vas deferens. So males with CF are infertile. Another problem is in the sweat ducts. So sweat duct is also a tube. If the CFTR channel does not work there, what happens is they will lose excess amount of salt in their sweat. So that will lead to a lot of salt loss, and incidentally that is the test which is done to diagnose cystic fibrosis, because you can measure how much chloride is there in the sweat and we can make a diagnosis. Now, so that was we were looking at the body as a big picture. But if you go inside the cell and look at exactly what happens, you can see on the surface there. On the surface there, we have. I don't know if you can see. This is the CFTR protein on the surface. This protein is made because of instructions which are coming from within the nucleus. The DNA has got the code to make any protein, including CFTR protein. So if the code is correct, if normal people have normal code there, so the mRNA will transfer the information, and in the ribosomes a nice CFTR protein will be made. That CFTR protein will be maturing over time by correct folding, and it will reach the surface. So that will lead to a properly functioning CFTR channel, and the patient will be normal. But at any point, things can go wrong. If the code inside the DNA is defective, that is the CFTR gene is mutated or defective, this process will not happen correctly. And as a result, many types of problems can happen. In the sense, at any point, the problem can happen. So based on this, so there are lots of mutations. There are described mutations. There are 2000. There may be many mutations which we don't know also. So these mutations are, for simplicity, they have been classified into 5 or 6 classes. So for example, in class 1, you can see the second picture, class 1 mutation, there are many mutations there. What happens is no protein is formed at all. That green thing is not produced at all. In class 2, some protein is formed, but the problem is it's such a defective protein, it will not reach the surface. So there's no use of making such a protein. Class 3, it reaches the surface, but it doesn't work well, it doesn't open. Class 4, it is little bit, it is there, it opens, but its function may be a little bit shaky. Similarly for class 5 and 6, there is some protein on the surface, but it's not going to be perfect. So 4, 5, 6, etc. are little milder mutation. If the patient has such a mutation, they may not have a very severe phenotype. Whereas class 1, 2, you can see there is no protein going to the surface. They will have very severe mutation, and you may identify this del F phenotype. You can see at the class 2 lower part, that particular mutation is the commonest. Now, so it is in the Caucasian population, it's a very common condition, affecting maybe every 1 in 2,500 births. That means everybody knows somebody with cystic fibrosis. But in certain population, it is less. In India, we don't know exactly. It could be as few as 1 in 40,000 or as high as 1 in 10,000. So that will be quite high. Now, this picture I have just borrowed from Dr. Kabra, this picture, the slide, basically just considering the population of India, even if the frequency is 1 in 40,000, there will be 500 new babies born here. If the frequency is high, there will be 8,000 babies born per year in India. That means all of us have to see a few patients because there are 8,000 babies added every year. If the frequency is that high, it may be less than that, or it may be more than that. We don't know. Now it's grossly underestimated. Maybe many reasons. One is really awareness. Another point we need to consider is consanguinity is very high in our population. So even normal, wherever consanguinity is high, the predictions, it will be more than the prediction. So we are not taking into account the consanguinity when you predict. So if you have consanguinity added to that, there will be much more numbers, especially in Tamil Nadu, Madurai, Vellore, etc., where the consanguinity is very high. So inheritance, it is an autosomal recessive condition. So mother and father are carriers. That means of the 2 copies, 1 copy is defective. Their gene, CFTR gene in the nucleus of their cell. There are two alleles or 2 copies are there. 1 copy is defective and 1 copy is normal. In that case, that individual will be a carrier and will not have any manifestation of the disease. But when you talk about the offsprings, the chance of having an affected offspring is 25%. You can see that child in the black or the darker color is affected because he has inherited the defective gene from the mother and the father. But children who inherit 1 defective gene and 1 normal gene will be carriers. So 50% chance that couple can have a carrier baby, 25% chance the couple will have an affected child, and 25% chance of a normal child. So altogether, They can have normal, phenotype child 75%. It's only 25% chance they will have an affected child. But that is just prediction. This happens randomly. So some families again and again they may have babies affected with CF. This is the chance in each pregnancy. When the mother is pregnant, the chance that baby is affected is 25%. It is a statistical chance. It may not work out to the reality. It may be all the time, it may be affected also. So the most common mutation in Caucasians is del(F)-phenotate. In India, it is less, as again, it's 70% or 80% in the Caucasian population. In our country, it may be only 30% or less than 30%. So in Madurai, there are certain mutations. Del(F)-phenotate is common here. There is another one, C1029 del, plus there are some duplication genes. These are all common around this area. Now, if you know the genotype, if you know the genetic mutation, can you predict the phenotype? Can you say, okay, we got this mutation, so the life will be like this? The thing is, we can't predict. All we can say is, if they have a mutation belonging to the milder, that class 3, 4, 5, I showed you the picture, they may have relatively milder disease. But there is so much of variation. Same mutation, two individuals may behave in totally different way. So knowing the genotype will not help you to tell the parent or the patient how their life is going to be. Pancreatic sufficiency, many of these patients are pancreatic insufficient because the duct of the pancreas get blocked by this thick secretions, and they don't produce the pancreatic enzymes enough to digest the food. So pancreatic insufficiency is very common. 85% will have pancreatic insufficiency, but certain mutations are known to be pancreatic sufficient. So luckily, if they have that mutation, they may remain pancreatic sufficient throughout their life. The others are more likely to be pancreatic insufficient. So that is the only thing you can say genotype correlates with phenotype. Otherwise, you can't predict at all. So for diagnosis is sweat chloride. So today we have done a few sweat chlorides. Some of you have come and seen how it is. So initially you induce sweating by pilocarpine, using pilocarpine, and then that sweat is taken and analyzed for chloride. That is one way. The other way is to find two mutations by genetic test. So the patient should have two pathogenic mutations. Then you can say patient has got cystic fibrosis. These are the main diagnostic tests. Now, this treatment I am just putting in just one slide here because it's a huge topic, but the summary of it is that you have to treat the lung. So in the lung, you saw the picture before, it is obstructed. When it is obstructed, the bacteria get in and stay there. So there is infection, mainly Pseudomonas, Staphylococcus, Burkholderia. These are some of the bacteria. And when there is a lot of bacterial infection, there will be inflammation. So this obstruction, infection, inflammation is going to destroy the lung. And we have to address this. How will you address this? We have to remove the stuff, the blocked mucus using airway clearance therapies. It may be chest tapping, it may be breathing techniques, it may be coughing, and also using hypertonic saline nebulization. So 3% or 7% saline is nebulized to kind of make the sputum thinner and then cough it out. Antibiotics are needed for infection. In the GI, main problem I said is in the pancreas because the pancreas duct is blocked and the enzyme is not coming out to digest the food. So they have severe malnutrition and malabsorption of fat-soluble vitamins. So we have to replace enzymes and we have to replace vitamin A, D, E, K. With every feed, the child has to take the enzyme. Only then that feed is utilized in the body, otherwise it will be wasted. Salt replacement, because a lot of salt is lost via sweat. This is a multidisciplinary care. Doctor has very little to do here. The main treatment is by a lot of others, many different specialities, many ancillary staff, nurses, respiratory therapists, physiotherapists, dietitians. They all have to work a lot to make the children, do better. And over time, complications develop, so we need to look after complications. So the whole treatment I have summarized into one slide. Each one has got many, many subheadings, and you can read that up because there's no time to go for that. So we are going to look at a few cases just to encourage discussion, and some practical problems which are faced in management we can address when we look at this case. So these are all true cases, just the name is changed. So please listen to because after this I will go to the question slide. So just remember what is written in the first slide. So this is a term baby born at 2.5 kilo, one of twins with normal neonatal and antenatal period. So very good so far. 2 months baby developed diarrhea and also some skin lesions around that time. Around 3 months, some cough, coryza, all that. But it is the only thing is it is not going away. It is just staying. By 4 months, diarrhea is continuing. So some doctors said stop the milk. It may be some milk allergy or something. Started on formula, which further complicated the problem because hygiene also is a problem then. So baby became a little bit more worse. Baby started dropping weight, losing weight. Diarrhea was ongoing. So had a hospital admission. Some of the diagnosis at that time is because of the skin lesions, acrodermatitis, enteropathica, those lesions, malabsorption, milk allergy, all this was suspected. Also, echo showed a small ASD. Some treatment was started for that. By the time baby reached 8 months, there were 4 admissions for pneumonia. So because there was really no solution to this, TB treatment was started, not because identified any bacteria. TB treatment was started empirically. That also went on. At one time, blood culture grew staphylococcus. At another time, a bronchoscopy was done. So Pseudomonas was identified from the ball. So this is all like a summary of this baby up to the age of about 1 year or 1.5 years. Now if you were to see this baby at that point of time, when would you have considered cystic fibrosis? And when would you have sent this patient for a testing? So you remember, neonatal period, obviously you're not going to do anything. At what point would you have acted? Any suggestions? Since there is some audience here, I'll ask here first. So it is difficult because these are very common conditions and many babies have these problems. So at what point are you going to recognize this is going out of hand? This is not normal. Definitely admissions, when patient gets admitted more than one time, all pediatricians will be like, there is something wrong here. So this is one question you need to consider. A lot of patients come, many have diarrhea, many have pneumonia. So, but when it is recurrent or persistent, or there is failure to thrive going on at the background, it can't be normal. It is not just one-off problem. It can't be normal. There is something underlying. It need not be CF. It can be immunodeficiency. It can be some other conditions. But definitely, at that point, you need to investigate. So, in evaluation of chronic diarrhea in infants or respiratory symptoms with failure to thrive, you need to act, and along with other differential diagnosis, you must consider CF also. You can consider everything else, but CF also has to come there. Especially if you find a triad of anemia, hypoalbuminemia, and edema. In this patient, there was failure to thrive, there was edema, height and skin lesions, hypoalbuminemia might have been there, and some of these babies would have got a transfusion. Sometimes that is the first thing, 2 months, 3 months requiring a transfusion. So even if you are ordering blood for a baby who is 3 months, because you can't say iron deficiency anemia in 3 months, it does not happen at 3 months. So even if you are ordering blood for a baby with infant for anemia, you must kind of think, CF, is it a possibility? And if you have failure to thrive and anemia and hypoalbuminemia, definitely that becomes a very strong case there. So earlier the diagnosis, better chance of survival, because the more days you wait, another 15 days, baby may die in front of you. So it is an emergency, we have to act then and there. And we have to discuss with the parents the importance of diagnosis, because they may say, we don't have money now, we can't do this, we can't do that. We don't want to travel to make the diagnosis. This is very, very important because they can't see the future, but you know from your experience what is going to come. This baby is going to die. And if you don't have a diagnosis, we can't help this family with the next baby also. So it's extremely important we have a diagnosis and we have to, get that across to the parent. And this particular baby has a twin. So we have to screen the twin. Twin may have the same problem. If you have sweat testing is the gold standard, that has to be done. If that has, sometimes blood sample for mutation studies may be helpful. That is not the gold standard, but if you collect a blood sample, that will be good in case something happens to this baby. But do not delay treatment waiting for confirmation of diagnosis because mutation result will come months later. Even if when it comes, it may be a question mark mutation, so we may not know. So do not delay diagnosis, start treatment. So what will you treat for this baby? What is the first thing we need to treat? Any suggestions? So here this baby is already malnourished and respiratory symptoms are there. So we have to address that. So pancreatic enzyme replacement is the first step along with all the other steps. All vitamins have to be replaced, A, D, E, K. We have to start chest treatment, physiotherapy and antibiotics. So that is, everything together has to start very intensively and aggressively. That's the only way to save this baby because already we have gone into recurrent respiratory infections. So those are the general principles. This baby, this child came from Andhra Pradesh. This is born to non-consanguineous parents. Perinatal period was all normal. Birth weight was normal. First 6 months very well, no problem. Around 8 months, weight at that time is 8.5 kg. Anybody will be happy with that weight. Baby is doing very well. Developed some respiratory symptoms, frequent recurrent cough, some wheezing. They used antibiotics, needed 2 hospitalization by the time she is first 1 year. And from 8 months, she is not gaining weight. 8 months, she had 8.5, but after that, she is not gaining. So mother had started some weaning, so everyone blamed her for the way she was weaning. She had used some multigrain powder. So after that, there was some oil in the stool, so they thought maybe because you gave all those things, she is developing that. So they stopped all that, and they just waited, stopped the nut mix. And she got a little better because when you stopped all those rich food, her stools also became better. In the next 2 years, child had multiple hospitalization. So 2 doctors said work up for malabsorption, but everybody in the family said no chance, no such problem in our family, so let's not go. So they didn't do anything till about 2.5 years when the child became on oxygen with pneumonia. So this is how quickly things go from bad to worse, Baby is okay 6 months back and then another 6 months, situation is totally changed. So that is why we have to act very quickly. So by 2.5 years, this CT scan is showing some bronchiectasis in the upper lobe. So imagine it's a very small 2.5 years, already bronchiectasis is there. Now what's going to happen in the next few years? The bronchiectasis is going to get worse. So the question we need to discuss is, so if you had seen the baby between 8 months and 1 year, the time when the diarrhea was happening, that she had given weaning, what would have been an appropriate management? So, any comments? I'm not spending much time on comments because of the time, but any suggestions? So, when they say oil droplets, normal persons, at one time, maybe during an episode of diarrhea, some malabsorption can be there. But consistently, oil droplets in the stool is not normal. It likely to be cystic fibrosis, but it is wrong. It is not correct. There is something wrong. It has to be evaluated. And along with that, baby is not gaining weight. So 8 months to 1 year, they notice the baby is not gaining weight, and there are oil droplets. So the action should have been taken then and there. Actually, one of the doctors had suggested, but the parents were not interested at that, parents or grandparents. So that is the one point we need to, the first flag, red flag, we have to act. Otherwise, it may be too late. Now, the other thing is, what do you think of the progression of GI symptoms in the first 2 years? So the first 6 months, baby was perfect. Weight was gaining. How come? Why is that? That is because it may take some time for the pancreatic duct to get obstructed and the function to fail. So even if some 50% function or 40% function is there, it will digest the milk and whatever food the baby is taking at that time. So the symptoms may not be there. Only when the fat content of the food increases and as the days go by, the pancreatic function decreases. Because sometimes even up to 3 years, 4 years, they may not complain of anything. So just depending on the patient's history, we may not be able to make that diagnosis. We have to test the stool for enzyme called elastase to confirm pancreatic insufficiency. So history is not reliable. Sometimes truly in the first few months there must have been pancreatic sufficiency. And it was failing. It was coping for some time and we didn't really find it. And counseling the family, it's very difficult in this kind of situation, but we have to look after the life of the baby. Parents don't understand it now. So it is our responsibility to convince them and we have to take that extra step. So this child is now 4.5. She was admitted 1 month back. She's not doing good at all. Her lung is very bad. They are actually parents who have some money. They are not very poor patients. Actually, they could have, treated aggressively and the child could have been so much more better now. So she is 4.5 and bad bronchiectasis and very bad paediatric type. So this girl is, okay, I'm just going to ask those who are on the online, can you hear me well? Because I am turning in between. Audible if you are possible. Can you hear me?
Yes, ma'am. Yes, ma'am.
Okay, thank you. Okay. So case 3 is another girl. She is in the adolescent age group with well-grown child. She is sent here for management of sinusitis. Actually, she is an ENT patient. Sinusitis is the only problem. And she had a polyp surgery outside and again it's growing. That is her problem. They didn't even say they have any respiratory symptoms. Only when really asked, they admitted there was some cough and wheezing and all that. Some maybe it is worse at night. When she plays basketball, she gets some wheeze, all that. There's no family history, non-consanguinity marriage. There's nothing there. So in that kind of situation, what will you think? A well-grown 13-year-old girl has some nasal sinusitis and she has some wheezing, cough, exercise-induced symptoms. So obviously we are going to treat for asthma. We are going to think of asthma first. That is a common thing. So we will do that. But even when you make the diagnosis of asthma, we have to keep in mind when you are examining for asthma, there is nothing to see in asthma in examination. What we are examining is to see if there is any red flags. So red flags may be clubbing, failure to thrive. There is no failure to thrive here. I already said that. Clubbing, any crepitations, these are some red flags in asthma, focal findings, etc. So when you examine, if you find any of that, then that is not asthma. Okay, that direction is wrong. You have to change your direction there. So in this case, what happened? Like I said, we have to exclude that. Also, wet cough. Asthma, they don't have a chronic wet cough. They may cough here and there, but everyday coughing is not a problem in asthma. And polyps is not a feature of asthma in children. In fact, children don't get polyps unless they have some CF or some other problem like that. So any red flags you have to investigate. So when we look at this child, she had clubbing and she had a wet cough. She had chest crepitations and her CT showed some early bronchial wall thickening and sinusitis and nasal polyps. All this is, we are going in the direction of cystic fibrosis, except she is not failing to thrive. She is a very well-grown child. You can see height is perfect, weight is perfect. She looks very well. Okay. So basically, I have not finished. I'm just summarizing from these 3 cases that it can be a very severe presentation from the 2nd month, 3rd month, 4th month onwards. It can be little well period, everything looks fine and then going down. Or it can be very well-looking child, you just can't believe it is here. So the spectrum can be anything, but all can be CF. So many of the patients which we think in OPD and you say asthma or TB or something, you look at it again and see, do we have evidence? that this is asthma or there is bleeding. If you don't have evidence, you have to look at it very closely because it could be something else at the same time. So this child, again, the diagnosis was late. He had respiratory symptoms. This father was asthmatic. Child also has asthma, has some atopic symptoms. So we diagnosed at 4 years that he has cystic fibrosis. With treatment, he was doing well. You know, his malnutrition got corrected. His weight was at the 50th centile. His lung symptoms came down a lot. But by the time he reached 6 years, he had this long, prolonged period of cough, production of sputum, etc. He got antibiotics for Pseudomonas, which was in the culture, but he didn't really get well. In fact, his spirometry was looking worse than what it was before. So in that kind of situation, child has got CF. We have made the diagnosis CF. We are following up the child, and this child is not doing well now. Okay. So here, what should you consider? What action should be taken? Again, I am going fast. So a child who is taking all the treatment, if the child is not taking the treatment, then it is not going to get better. That is common sense. But the child on good treatment and still going down, you have to think of some resistant pathogen has colonized, or maybe an intercurrent, some viral infection, you know, COVID or something else has happened. That's the reason. Maybe the asthma part is not controlled in this child, or some allergic rhinitis or some comorbidities there. Then there is another entity called allergic bronchopulmonary aspergillosis. I won't go into the details of this. This is a complication which can happen in cystic fibrosis patients. It is an abnormal response to aspergillus fungus. Aspergillus fungus is everywhere. All of us have some aspergillus in our lab. We are not going to react to it. But cystic fibrosis patients can abnormally react to aspergillus, and their lung situation can become even worse. So the obstruction gets worse, the bronchiectasis get worse, etc. Then another problem, complication these children can develop is diabetes, because the pancreas, like I said, initially it is almost normal, it gets worse and worse and worse. Finally, the whole pancreas gets destroyed off. At that point, the islet cells, the insulin cells also will go. So they may develop diabetes. So at that point, their clinical condition can deteriorate. So that may be the situation. So this child had ABPA workup positive, and sorry, it's not asthma ruled out. This asthma is under control, but ABPA was positive. So he was on inhaled steroids, and he in this situation needs treatment with steroids. So that is his CT scan, lot of mucus plugged airways. Okay. So this is another baby who came in the summer, 3-month-old baby. So I saw a few patients like this here today also. This is one characteristic problem. What happens is because they have salt loss. We said no, the duct will lose salt a lot. So in summer when they sweat, they lose a lot of salt. So normal, if you check go down and do our sweat chloride, it may be like 10 or 12. Whereas these patients will have a sweat chloride of 88 or 99 or something. That means they will lose 10 times or 9 times more salt than this. So a small baby, an infant with a large surface area, when you expose to hot weather in Madurai, they will lose all the salt, sodium, they will become hyponatremic. See the sodium of 100. Hypokalemic, and then bicarb goes up. That's a metabolic alkalotic state. So when you see an ABG looking like this, for anybody, chloride, if you measure, that also will be very low. So we were looking at the child in ICU with a little low chloride and potassium, but the baby has other problems also, so we don't know what's going on there. So, but when you see this picture, you must think of cystic fibrosis, and so this child was finally diagnosed to have CF. So summer dehydration or Pseudobarter syndrome at that time, many of these patients are sitting with a nephrologist because it's a very typical Barker kind of an appearance. And the problem may manifest only in infancy. After the first 1 or 2 years, they will take salt and water and they may not manifest at all. Some of these mutations are very mild and problem starts a few years later. So these children, even now we have diagnosed. Very difficult to convince the parents there is something wrong with the baby. Because after summer they are well. they will spare that there is no respiratory problem or a GI problem. They won't come and say, just now I was talking to a family, they had stopped the treatment because they won't be convinced. Child looks so well, but as the time goes by, another few years down the line, they have bad problems. They will start knowing. At that time, you can't do anything. So we have to do whatever we have to do right now. So when you counsel them, so I've just written, if you start all the treatment, you have to tell them about the next summer or when the baby is exercising, the baby or child is exercising to add on more salt and water. So a high index of suspicion is needed. They will be walking around us. We may not realize they have cystic fibrosis. So the cost of missing the diagnosis is very, very high. It's a high cost. We have to pay with death of the child. Okay, that is the cost. So as we discussed, the incidence may be very high. We have consanguinity. One thing, not just consanguinity, it's endogamous marriage, which means we marry only in the community. You know, we have some few communities here. We will marry only within the community inside the language. Tamil Nadu people won't go and marry Kerala people. So if you are marrying again and again within the same community over many generations. So the mutation is sitting inside. It's going into the community again and again. Right. So as the time goes, you don't have to ask for consanguinity because you won't get. They won't know they are related. But you know, 5 generations back, they are all related to each other. So that endogamous marriages again will increase the frequency of the condition. That is what is happening right now, I think, because we find parents are non-consanguineous, but they have the same mutation. It's just because the number of mutations are so high in the community. So the early manifestation, as we saw, pneumonia, diarrhea, malnutrition. Now, if you look at any infant mortality data for India, what kills pneumonia, diarrhea, malnutrition? Now, how many of them have CF? Have you inquired whether they are dying of CF or not at 2 months or 3 months? We have not. So this is what I did in my own hospital, 3 years, 2018-19. So the first column is deaths in the first 12 months. 1 month, not neonatal period, because they die of many things. 1 month to 12-month baby, 2018, there were 52 deaths. Out of that, 33 were within the first 6 months, 1 month to 6 months. 33 deaths happened in 2018. So CF confirmed in 3 patients, and 2 more might have had CF, but I was not able to confirm. So there were probably 5. That means 15% of them, 9% for sure, maybe 15% had CF and died. Now, mind you, these are not the patients who are referred to as saying these patients are CF. These are patients who feel like everybody else. They live around Vellore. When they get pneumonia, they come to us. Similar to any of your patients who are getting admitted in your ICU, they have a problem, they come to you. Nobody knows they have ICU. They are less than 6 months. They haven't had much life to diagnose it. So you look at 2019, similarly, you know, if you consider the likely also, this +2 is because I didn't get the blood sample or we didn't confirm it. That's why I did the +2. But that is more likely to be correct. So 15-70% percentage of the deaths in that age group are probably due to CF, which is a very high number for infant mortality. Now, if you, now the red is, just I repeated the same thing. If you look at the other causes of death, congenital heart disease is about 21% of the first line. At the same time, babies with the diagnosis of sepsis, pneumonia, some other pneumonia, bacteria, some other pneumonia is 45%. And other causes is 18%. So the highest is sepsis, pneumonia. Second is congenital heart disease. Third is cystic fibrosis. Okay, that is in our hospital. They are not referred as CF. Nobody knew they had CF. It is on the last moment we are diagnosing or suspecting as CF. So if this is the third most common death in our own hospital, it can be very different from your hospital or Madurai College or College or because the same type of patients come there. You know, so a little sick. You know, they come and get admitted, they die, etc. It could be the same. I don't know. So you have to look at your data. You know, you have to retrospectively look and see which among them could have been CF because we have some clues here. You can use that clues to see Now you can't confirm it because you don't have the blood sample or you can't confirm it, but even prospectively you can confirm. If you look at the next 1 year, what's going to happen. So for pneumonia, there is a national program for detecting these are preventable deaths. They need not die at that time. Maybe eventually they will die early, but this need not be part of the infant mortality rate in India. They can easily go beyond the infancy and childhood and much beyond that. So this is something which we can prevent. So this may be still the tip of the iceberg. There will be lots more beneath this. And there will be remarkable clinical improvement when you make the diagnosis and treat, and definitely avoid deaths. And also other thing is genetic counseling. The parents can be told and they can do ability diagnosis and prevent the death of another baby, the birth or the death of another baby. So this is some pictures, that's the first, you can see that picture, that baby when they came, edematous, malnourished, very sick, skin lesions. Within few months of treatment, see that beautiful leg. Same for the hair, the flag sign and all those signs. It's just beautifully gone, just with pandemic enzyme replacement and nutrition treatment, and you can reverse it. This baby, this is the fourth baby of that family. 3 babies died. Second one, third one, fourth one. None lived beyond 4 months. Okay, they all had cystic fibrosis, but nobody knew. They were treating as different diagnoses. This one we made a neonatal diagnosis and treated this at 5 months. See how chubby the baby is. So you can keep them very normal. I mean, not absolutely normal. They still have cystic fibrosis, but their condition can be very well managed. So among Indian states, if any state can take the lead, it is Tamil Nadu, because our medical setup, and Kerala may have the medical maybe equivalent or better, but I don't think there are that many cases there. Whereas Tamil Nadu, there are lots of cases. There are lots of patients dying, babies dying, and we really need to take the lead and lead India in this matter. The other way to diagnose or detect is screening of newborns. So what is done is at birth itself, on just a fingertip or a clean prick blood sample, we can check an enzyme called IRT, immunoreactive trypsinogen. Trypsinogen is an enzyme which is coming from the pancreas. So even at birth, these babies have a pancreatic problem, and their trypsinogen level will be high. So all babies we can check IRT and find if they are high, they are likely to have CF, then we can test them using self-testing and we can diagnose. But all over India to do it is a big, logistics, the money involved, the training involved, that may not be easily done anytime soon. But we can use simple strategies. What are the simple strategies? If any baby is failing to thrive, so when they come for immunization, very important to put their weight on the chart and see where the weight is. If the weight is at 3rd center, 2.5 kilo baby born, when they come for immunization at 6 weeks, they should be 4 kilo or 3.75 kilo. 1 kilo definitely has to increase, right? If they haven't made that, you have to stop here, drop everything. There is something wrong here. Okay, maybe some dilution or they are giving some milk or something. There may be some explanation. You can give them 2 weeks time to correct it. If within 2 weeks they are still failing to thrive, you have to act. You can't let them go. Because if you let them go, if there is a CF with that, they will die off 3 months, 4 months later. So failure to thrive is not just cystic fibrosis. It can be immunodeficiency, it can be heart disease, it can be urinary problems. Anything. Failure to thrive is serious in a young infant. So even if you can't do newborn screening, if you can identify babies who are failing to thrive, or babies who are presenting with summer dehydration, like we said, before their problems start, you can pick them up at 6 weeks or 12 weeks when they come for immunization. Screen them. If you have any doubt, you can confirm the diagnosis, and then you can proceed from there. It will be a great service to that family because they don't need to see the death of that baby, nor the death of subsequent babies. Okay, that's a very serious thing we can avoid. So aquagenic wrinkling test, I think many of you are familiar. It is just dipping the hand in the water for some time. So cystic fibrosis babies seem to wrinkle fast. The tip of the fingers, you can see the wrinkling developing. So this is a screening which is used. It's a very, it's not a very fancy test, but it gives us some direction. If they are positive, maybe cystic fibrosis need to be definitely considered. I mean, not everybody who wrinkles does not have specificity is not high. So other conditions also wrinkle. So it's not like 100% we will have cystic fibrosis. But we have one more point to tell them, please go get tested. They can get the diagnosis. So I mentioned the treatment principles. Now, new treatment strategies, just for completion, I am just saying this. You remember the picture I showed you. So the cystic fibrosis protein is formed at the surface through many steps. Now, we said problems can happen anywhere. Now, there are 2 or 3 major drug molecules which have been developed in the last few years, which have really changed how CF is seen abroad, because these medications are available. One drug is for mutations in which the CFTR protein is there on the surface. We showed that class 3 mutation. The CFTR protein has reached there, just that it is not open. So if those mutations, the children with those mutations can be given a drug. One of the names is ivacaftor. If you give that drug, that molecule will open this channel. So the problem is solved. They can be normal. The chloride will come out, everything will get clear. Okay. So ivacaftor is one drug which can be used for class 3 mutations. Then there is another drug which can be used for the most common mutation called del-F phenotype, in which in that problem the defect is in the maturation of the cystic fibrosis protein. You can see that mature CFTR, that is where the problem is. So that molecule will correct that. So those molecules are called correctors. So correctors, and the first one called potentiators, or a combination of the two. These drugs have revolutionized the treatment. Now in the Western countries, especially USA, they treat, and within 1 week they are so much better. Children, patients who are ready for lung transplant, saying next week we are going to operate, they discharge them from hospital within 3 days of oxygen and say, go home, we will see you later. They are not completely cured, we have not cured it, but the problem is solved for now. So it's a very magical drugs are available. It is available, it will come sometime to us, but we don't know when it's going to come. Right now it's extremely expensive. So we are not talking about that right now. But remember, even right now, very effective treatment used in all countries are available in India. Which are those effective treatments? Hypertonic saline nebulization, chest physiotherapy, just the mother's hand, and tapping, coughing, clearing, using antibiotics, the correct antibiotic, correct food, the dietary manipulations, enzymes, vitamins, salt. These are all the treatment which all countries are using. In fact, countries like Australia are using only this. They have not started the new drugs. Okay. So we can treat as well as any other country. Only problem is we are not diagnosing early. There's no problem in our ability to treat. Our problem is we are behind in diagnosis. Not because we are not smart or anything. Indian doctors are much smarter than anybody else. Okay, because clinical diagnosis, suspicion, everything, we are much higher than everybody else. It's just that we just believe wrongly that it is not here, or we are not going to see. But if we just change that attitude and say we are going to see it is there, some of the children have cystic fibrosis, we start looking, we will find. If we find, we can diagnose, we can treat, we can make life better for that child. Definitely, we can help that family with the future pregnancies. So these are some of the benefits of early diagnosis and treatment. So I have just presented in a very, it's an overview. I have not gone into details of any aspect. Please read on that. Anybody has questions from the online group? You can chat box also, you can write if you want, or you can ask. Yes.
Ma'am,
Tell me. Yeah.
this is Dr. Kadireshman, senior resident from Velamal Hospital.
Yes.
I'm downstairs, ma'am. Just wanted to ask you.
Yes.
A known case of CF, cystic fibrosis children, whether do we have to treat the Staphylococcus aureus or Pseudomonas aeruginosa colonization? Do we have to treat, or infection we have to treat? How to identify whether it is colonization or infection?
Yeah. Okay. So Pseudomonas and Staphylococcus. Pseudomonas especially tend to colonize. So the first time you identify, you have been seeing the child before and cultures were negative, and the first time you identify the Pseudomonas, you must try to eradicate it. So there is an eradication regimen for this long antibiotic by oral or inhaled or IV, whatever. So that's an eradication strategy, because if it stays there, it will colonize. That means it will just put up the tent and stay there. So if once that happens, their lung functions really go down. So the first time you see, you try to eradicate by a prolonged course of antibiotic. If then you do a culture, if you fail, you can try once more eradication. So traditionally, we try 3 times to eradicate. If 3 attempts at eradication have failed, then probably it's not going to come off. It's going to stay there. So then we say it is colonized. So once it's colonized, then there's no point treating every day. So you'll probably treat when there is an exacerbation only. But colonized patients also can have alternate week, alternate month nebulized antibiotic like gentamicin or colistin, just to keep the load of the bacteria low. So that can be done. Azithromycin 3 days a week can be used for Pseudomonas colonized patients. Okay. So the answer is treatment or eradication is when you detect first 2-3 times you try to get it out. After that you say, okay, we failed, we will live in harmony. Like, it's going to sit there, we are going to sit here, like, we will accept that as colonization. Yeah. Okay, I am signing out for the quiz.
Okay, thank you very much, ma'am, for enlightening us about this disease, which was thought to be rare, but actually we are diagnosing it more frequently nowadays. We wanted our PG students to give more attention for identifying and diagnosing. That's why we are conducting the quiz now, postgraduate quiz regarding cystic fibrosis. I request Dr. Karthik Raj and Kadresh to take the stage.
Thank you, ma'am. So before going into the quiz, I would like to thank Sneha ma'am for giving such a elaborate awareness about cystic fibrosis. I hope the information is taken and we don't miss cases of cystic fibrosis in future. So before going for the quiz proper, I would like to thank all the enthusiastic participants of today's quiz who had given an overwhelming response actually in a very short duration of time. We had registrations from Jitmar, Teni, Keelpok Medical College, Mehta and Madurai Medical College, along with Mahatma Gandhi Medical College as well. So I will first like to ensure that all these participants join the link. So anyone from Jitmar, can you just update me on status? So Sanjeev or say Abhishek?
Yes, sir, we have joined.
So if Sanjeev, Minnala Devi, Sasi Rekha, Sanjana, Archana, Shekhar Das, have all of them joined? So kindly ensure.
Okay.
And again from Teni, Dr. Lavanya or say Dr. Jayakavya, can you ensure that all your participants have joined as well? Then from Keelpok, I hope all are joined. So please ensure Nandini or Preeti, please ensure that all of them have joined the link. Dr. Bhuvaneshwari, again, I think she has joined, and Dr. Renu Mageshwari from Mehta, then Dr. Sridhanya from MGM Pondicherry. So I hope all of you have, those who are willing to participate finally have joined. And I would give some common instructions before going on with the quiz. So as discussed earlier, we are going to conduct the quiz through an online mode with the help of an app called Kahoot. So I would like all the participants right now to go to the browser in their phone, and I'll be just sharing the screen. I'll be just showing you what you're supposed to, which site you're supposed to log in. It should be done in your mobile. So this is the site. So it is kahoot.it, kahoot.it. Fine, and you will get a window like this with a game pin to be entered. I want all of you to go to this particular screen and get this particular screen, and once you are done with it, I hope we can straight away start. So anyone having trouble with this side, just please tell us. Otherwise, I think we can just go on with the event. So, and I also ask all the participants to kindly switch on their cameras. So please switch on your camera. Kindly switch on your cameras. Fine. I hope you have switched on your cameras, and so be ready with the screen that is on your mobile, that is kahoot.it. So this is going to be a game where it's going to be a multiple choice question. Again, we didn't announce it as a prize event. We just wanted to create an awareness in a learning mode. So I first thank all the participants again for showing so much interest in attending this. So some of you might have been aware of this Kahoot, some might not have. So I will just give you a brief thing about this. So once we are just going to start with the question, it will be a single question with a 20-second timer, and you will have multiple options which you can select from your mobile directly. Correct answer will get you positive marks. You don't have any negative marks. If you're not answering, or if you answer it wrong, you will get a 0. And the important aspect about this particular platform is that the earlier you answer, the better are the scores. Say for example, the next second or a few seconds later you answer, you are going to get full marks, that is 1000. And the later you answer, lesser will be the score. And we will be showing the track of the podium after each question. So you will know who is topping the list. So the audience as well can see who is coming first after each question. So again, this is just an awareness event, and I hope it's not just an awareness, or you will get more learning points as well. Now I invite Dr. Kadiresh, a senior resident of our department, who will be proceeding with the quiz, and he will be interacting with you and giving you some valuable inputs as well. So to Dr. Kadiresh. So I hope you are able to see the PIN number. So kindly enter the PIN number. Kindly give your original name. Don't give any nicknames. Please give your original names. join soon, we'll be just.
Sir, how to join?
1 more minute for you to join.
Sir, how to join?
Only 10 participants are joining so now. So please ask your friends to join early. So,
Who wants to join?
so is anybody having trouble opening the site? So we have only 11 participants right now. Many are yet to join. Because once we started, we cannot stop. So please ensure. Sanjeev, please ask your friends from Zipmer to join.
Okay.
And Lavanya, your other participants from Genie.
Any problem in lobby to Kahoot, just let us know.
Okay, so we will start. Again, we didn't get all the full participants into Kahoot, but we are right now leaving this game open so that they can join in the middle as well. So we are starting with the event.
Hope you are clear with the rules and regulations. So once the question is asked, you have 20 seconds and 4 options. So in your mobile or lab, you'll be seeing the colors. So you have to choose the correct color. So depending upon the time you take, you'll be getting your point. So after each question, the position will not be static. It keep on changing. So right now we can start the quiz. So this is your first question. So, as you can see, out of 11 participants, 10 have responded. 4 persons have secured the right answer. So the answer for this question is Staphylococcus aureus is the most common pathogen to colonize. So now you can see the score. Sanjeev from Jupiter leads with 954 points. Second question. So almost majority you have answered correctly. The total number of amino acids in CFTR gene is 1480. So let us just go to the scoring board. Sanjeev Jipmer 1920, following which Akash Chandran from Jipmer 1855. The correct answer is 2500 units per kg per meal. Whereas for an infant, totally 2000 to 4000 units per meal is adequate. So now the top position changes to Dr. Nandini from Hill Park Medical College. Male sex has got better prognosis in CF. Answer is immunoreactive trypsinogen. So Dr. Nandini is leading from Teni Medical College. The answer is the most common mutation F508 deletion is going to affect the nucleotide binding domain 1 of the CFTR receptor. This is an intracellular portion of CFTR receptor. Okay. Usually, CF children, in order to treat Pseudomonas aeruginosa infection, aminoglycoside, the dose and as well the frequency to be given 12 hourly. So let us see the scoreboard now. Dr. Nandini from Teni Medical College is leading. So as you can see, meconium ileus is the earliest clinical manifestation, which will present even within 48 hours of life. Dr. Bhuvaneshwari is moving up close to Nandini. Three of you have answered correctly. So it is 3849 plus 10 kilo base pair, cytosine to thymine mutation. You will have normal sweat flow rate. Dr. Bhuvaneshwari leads 6,383. She is from Madurai Medical College. So the answer is class 4 and 5. CFTR receptor will be present in the apical membrane and also it is functional. In class 4, there will be reduced chloride conductance. In class 5, overall the quantity of CFTR, functional CFTR produced will be very less. Again, the scoreboard remaining the same. Bhuvaneshwari from Madurai Medical College leads. So 7 of you have answered correctly. It is respiratory failure, which leads on to core pulmonary, right-sided heart failure. Respiratory and cardiac failure is the most common cause of death in cystic fibrosis. Okay. So 4 of you have answered correctly. The route of administration of levocapital, which is nothing but CFTR potentiator, it is oral. It can be given to children who are more than 6 years old. Nandini and Bhuvaneshwari, they are very close. Again, 50-50, 4 of you have answered correctly. Oral mucolytics, they do not have any role in the management of cystic fibrosis. It is the inhalational mucolytics. Most commonly we use is 3% hypertonic saline. Median age of survival in cystic fibrosis, it's about 37 years. Akash Chandran is moving up. Everybody has answered correctly. Ivacaptor, which is nothing but CFTR potentiator, has got a role only in this type of mutation. Glycine replaced by aspartate acid at the position number 551 in CFTR gene. And this belongs to class 3 type of CFTR mutation. Again, within 10 seconds, all of you have answered the correct option. Earliest pathological lesion in lung is bronchiolitis, following which bronchitis. Bhuvaneshwari is leading, followed by Dr. Nandini and Akash Chandran. you have answered. All of you are correct. It is more than 60 milliequivalents per liter. The cutoff level for sweat chloride for diagnosing cystic fibrosis. Let us move on to the scoreboard. Again, Bhuvaneshwari and Nandini, they are fighting equally. So the answer is G542X. It is nothing but class 1 mutation where there is no CFTR gene production. Okay. So more than almost all males are infertile because of defect in Wolffian duct structures. We call it as congenital bilateral absence of mass difference. That's the reason why males are infertile in fibrosis, and also they are azoospermic. So we are on going to our last question. Bhuvaneshwari has the highest answer streak of 12. The correct response is oral quinolones. The first choice of antibiotic in the management of Pseudomonas aeruginosa infection in CF children for a total duration of about 2 weeks. So the final scoreboard. Third place, Dr. Nandini from Keel Park Medical College. Second place, Akash Chandran from Chikma Medical College. And here comes the winner, Dr. Bhuvaneshwari from Madurai Medical College. So we congratulate the winners and also the participants of this quiz. We congratulate the winners and also the participants of this quiz. So winning or losing doesn't matter. So keep participating in future quiz competitions, and we hope this quiz session would have been helpful for you and also for knowing more about cystic fibrosis. Thanks for your time, and I would like to hand over this further session to Dr. Janish ma'am. Thank you.
Thank you, everyone. Participants who attended today. And coming to the final session, in places where we don't have the availability of sweat chloride, like many of the colleges, medical colleges, we don't have sweat chloride. So what are the other things we can do in our bedside? So that the final session, places where we don't have the availability of sweat chloride, like many of the colleges, medical colleges, we don't have sweat chloride. So what are the other things we can do in our bedside? So that so can any of the PGs share what you can do if we don't have sweat chloride? Jay Kavya, please mute yourself. Okay. So we'll have a very brief presentation about that. Open money tenants.
So,
Sorry for the delay. And it will be a very brief presentation about what we can do in our settings. So first thing, our students will be presenting it in a very short manner.
Good afternoon, everyone. Let's see about aquagenic wrinkling test. So, cystic fibrosis is a life-limiting genetic disorder which has multiple mutations associated with it. So, genetic testing as diagnostic tool is not feasible. And that too in India, with a population of over 1 billion people, using genetic testing is somewhat difficult because centers with this genetic testing facilities is available in less than 10 centers in India. So, studies have shown that aquagenic wrinkling in children with cystic fibrosis, the time is decreased when compared with healthy individuals. So for this test, examination of both hands were done. Images were taken to compare the results. Orvo purified water at room temperature of 25 to 30 degrees Celsius is taken in a standard tray and kept on a level surface. Now, one hand is immersed in water and the time is noted as 0. After 30 seconds, the hand is taken out and examined for 3 seconds for appearance of wrinkling. And this is done up to 3 minutes. When wrinkle appears, then it is taken as the endpoint and photographs are taken. So, the sensitivity of the test is about 81% and specificity is 56% because it occurs in other conditions like atopic dermatitis and hyperhidrosis and Raynaud's phenomena. So this test can be used as a potential screening tool and it is also inexpensive. So it can be used for early referral of the patient for diagnosis and it can decrease the overall morbidity in cystic fibrosis cases. Thank you.
Good afternoon. How to detect fat globules in stool? Normally, in a healthy individual, less than 6 grams of fat is excreted in stool. In steatorrhea, more than 20 grams of fat is excreted daily. There are various tests to detect the presence of fat in stool, and they are broadly classified into quantitative and qualitative tests. Under quantitative test, we have 72-hour fecal fat test. Under qualitative test, we have Sudan 3 stain test, acid steatocrit test, and NIRA. Coming on to 72-hour fecal fat test, a high fat diet is given for a period of 6 days. 70 to 120 grams of fat is given, followed by which stool is collected for a period of 3 days. In steatorrhea, more than 20 grams of fat is excreted in stools. Sudan 3 stain test. For detection of neutral fats, a small amount of stool sample is placed in a slide to which 2 drops of water, 2 drops of 95% ethyl alcohol, and 3 to 4 drops of Sudan 3 stain are added on a slide. Presence of neutral fats are observed as bundles or plaques which stain dark orange. For detection of fatty acids, 2 to 3 drops of 36% glacial acetic acid is added along with 3 to 4 drops of Sudan 3 stain dye. On flame heating, the fat globules will stain dark orange. Acid steatocrit test. It's a most simple, inexpensive test and it's based on the measurement of weight. Acid steatocrit percentage is equal to fat layer by fat layer plus solid layer into 100. NIRA, near infrared reflectance analysis, enables simultaneous measurement of nitrogen, fat, and carbohydrate. Fecal elastase test, it's the most sensitive and specific test for detection of the pancreatic function. Measurement of fecal elastase 1 is closely correlated to the pancreatic function. Less than 200 microgram per gram is considered as abnormal. False positive tests occur in cases of watery diarrhea caused by non-pancreatic causes and drugs. But this test is not very suitable for mild and moderate pancreatic insufficiency. It's only suitable for severe pancreatic insufficiency. Thank you.
I'm here to explain about how to take a cough swab and a deep throat swab in a pediatric age group. In cystic fibrosis patient, a progressive respiratory disease is the most important cause of morbidity and mortality. The most important organisms causing airway infections are Staphylococcus aureus, Haemophilus influenza, and Pseudomonas aeruginosa. So detection of these microorganisms in early stage is important before these organisms colonizes the lungs. So how to take a cough swab in a pediatric age group? Wash your hands and wear gloves. Use a spoon as a tongue depressor. If the child obeys your command, there is no need for a spoon or a tongue depressor. Ensure that the baby sits comfortable on the lap of his mother and ask the mother to secure the head of the child so that the child doesn't move the head. Introduce a spoon to depress the tongue and introduce a cotton swab under the uvula, preferably not touch the posterior pharynx. And ask the child to cough. If the child understands and coughs, remove the swab immediately and put it in the tube. If the child doesn't cough, introduce the swab till further and take a swab from the posterior pharynx. That is, we are converting the cough swab into a deep throat swab and taking the swab from the posterior pharynx near the tonsil. The throat swab after a physiotherapy gives more yield than a normal throat swab. In pediatric age group, we mostly prefer cough swab and deep throat swab because in pediatric age group, child cannot expectorate cough on our command. A quicker identification of organisms will prevent morbidity and mortality due to respiratory infection in cystic fibrosis patient. Let me share a video. Thank you.
So I take this opportunity to thank each one of you, and especially Ma'am Dr. Sneha Madam, who has come all the way from Vellore to educate us more about this disease, and the active participation by our postgraduate students from overall Tamil Nadu and Pondicherry, and our hospital management, my department colleagues, our supportive staffs, everyone who worked really well to arrange this in a very short time. I thank you one and all, and we would like to conclude this program. Thank you. அந்த ரெப் ஒருத்தர் இருப்பானே வரலையா? இப்பவே போறாங்க அவங்க. சாப்பாடு கொடுங்க, எனக்கு இது மட்டும் ப்ரொஜெக்ட் பண்ணுங்களேன், ஸ்கிரீன்ல வர மாதிரி. I didn't present it. இது வந்து ஜூம்ல இருக்கு, அது வந்து பவர் பாயிண்ட் ப்ரொஜெக்ட் பண்ணிட்டு இருக்கா. ஓ, இதுல இருந்து அப்போ ஷேர் ஆயிட்டு இருக்கோ. சரி சரி, ஓகே. இது சொல்லுங்க. தேங்க்யூல தான் நிக்குது. ஜஸ்ட்னா என்னோட ஸ்கிரீனிங் ஷேர் அதை வந்து கேன்சல் பண்ணும். இல்ல, நான் என் லேப்டாப்ல இருந்து ஷேர் போட்டிருக்கேன், அது இதுல வர மாட்டேங்குது. இது எப்படி ஹேங் ஆகி நிக்குது.